is Harita with 20 more questionnaire, and I wish you all to participate actively in this. Today's quiz is not that difficult. It's all just a simple review recollection for all your path memory you had in your memory in your amygdala. So I hope everyone are ready for the brushing of the syllabus. Uh, Fine. Okay, let's start the quiz. So I hope today is Janmashtami and everyone have made their own Krishna in their own home. There's quite a little delay. So meanwhile, let me give you, let us talk something interesting about. So I'll give you a case scenario. There's this 18-year-old man, brother of our staff nurse. So he turned up. The staff nurse was very much concerned about her brother, saying that he didn't reach puberty and all. We all were like, fine. She just did a general checkup on her own, and then we found very interesting. When we were seeing through all the blood smear, we found something in the neutrophil which I don't want to disclose it to you. Okay. Then after that, we asked for maybe there is a change of the sample. So we just cross-checked it again, and then there's no. We did it ourselves. We made a smear ourselves with his own blood, and then we still found that again. And then to our surprise, we asked him to get a physical checkup done by our male colleague, and then he said that yes, what we suspected is very true. And actually, he did that checkup for his gynecomastia problem. He has gynecomastia, young male, so he just want to get it cosmetically corrected. So then, in that process, we came to know that there is a bar body in his blood. So usually, in which situations you find bar body? Bar bodies are the small drumstick protrusions on the neutrophils of females. But we found him in this. So we have a question on that. So you know the most important karyotype of that. Okay. That is one question we do have. We have questions on congestive heart failure, and we have questions on multiple lung abscess. Okay. Okay, let's start the quiz. Here is our questionnaire ready for the presentation. So trust me, if you get one case, you will never forget in your life. Such is the case for me here. So yes, let's start the quiz. Thanks to all who are participating. And Sairam, I hope you're there in. Well, all the following symptoms are associated with Klinefelter syndrome, except this was the case I was talking about. He has large soft testes, gynecomastia, unicoidism, and azoospermia. So what, according to you, is not the feature of Klinefelter syndrome? Very good. They don't have large and soft testes. They have small and firm testes on the contrary. And yes, they do have gynecomastia and they do exhibit unicoidism and they do have azoospermia here. Okay. So now, what do you think the karyotype could be? 44 plus XXY, and they have one bar body. Okay. Fine. Next question. Let us see who wrote it correct. Well, Alkamani, Ravi Kumar, Sairam, Bacillus, hello. Okay, fine, good. Next question. So, see, 44-year febrile individual, multiple thin-walled abscess, cavities in the lower lobe, okay, patchy consolidation. So, what is your option? He's alcoholic with fever, fetid breath, and sputum containing a mixture of gram-positive cocci, gram-negative rods, and fusobacterium. Alcoholic with history of weight loss, fever, night sweats, and MON2 test positive. Smoker with a history of weight loss, malignant squamous cells, or is it hyponatremia? Okay, why did you opt smoker with a history of cough, weight loss, and sputum cytology showing malignant squamous cells? See, here the patient is having multiple thin-walled abscess cavities in the lower lobe of the lung, okay, and has patchy consolidation. So, multiple thin-walled abscess with patchy consolidation associated with aerobic and anaerobic bacteria. So, what are these? You have Staph aureus, Klebsiella, and you have fusobacterium. So these are all, what do they cause? They cause fetid, foul-smelling abscess, cavities. Okay, the patient clinically complains of fever and foul-smelling sputum here. So this is a classic case of mixed bacterial abscess. Okay, and PPD, that is purified protein derivative test, is positive in case of caseous necrosis and in tuberculosis. Where in tuberculosis, see here the lower lobe is affected. In tuberculosis, most commonly there's upper lobe which is affected. Okay, and then you have caseous necrosis. Malignant cytology, what they are close to the bronchus, so you do have that demarcation. Okay, they are in line with the bronchus. You don't you have a filled tumor, okay, not a cavity here. Maybe yes, if you have a tumor, or maybe because of this immunocompressed state, there might be a case of superimposition, but that is less likely. A smoker with history, of course, yes, that no one has opted, so no need of explanation. Okay, fine. Next question. Okay, Sairam, quickly, Al Kamene. So we have the next question number 3. So here, an elderly male with congestive heart failure for years with digitalis and furosemide dies of pulmonary edema. A postmortem examination of the heart would most likely show severe left ventricular hypertrophy, right and left ventricular hypertrophy, right ventricular infarction, and a dilated globular heart with thin walls. Straightforward question. He's having CHF and he's on digitalis and a diuretic. So what do you think is? Yes, why does majority opted severe left ventricular hypertrophy? He's having pulmonary edema. So what does happen in this after in congestive heart failure after decompensation? You have hearts that are maximally dilated, okay, and there will be thinning of the myocardium. Okay, there will be thinning of the myocardium. So what does it show? A dilated globular heart with thin walls. That is the case here in pulmonary edema. So right and left ventricular, no, those are not the answers here. Okay, next question. Let us see the leaderboard. Good. Ravi Kumar. I should call all. The Coombs test is positive in all except. I'll give you the options: primary sclerosing cholangitis, primary biliary hepatitis, chronic active hepatitis, and alcoholics. Coombs test is positive in. What is a Coombs test? Simple question. Very good. Majority wrote it correct. It is in alcoholics. In all autoimmune diseases, you have Coombs test positive where there is hemolytic anemia. Okay. In primary sclerosing cholangitis, you do have anemia. In primary biliary cirrhosis, you do have hemolytic anemia. And chronic active hepatitis, you do have. In alcoholics, you don't have hemolytic anemia. Okay, because you don't have any autoantibody. It is not an autoimmune disease. It is an induced one. And the answer is alcoholics. Next question. So this is a repeated question. I hope you all will answer it correct. The next one. Leaderboard, please. Good. I see the first 3 cream. Hello, JD, good boy, Bacillus, Dinu. Fine, fine. Come on, push up. Come to the cream. Yeah. Next question. Question number 5. So the pathology appearance of coagulation necrosis of fibers and the evidence of extensive neutrophilic exudation usually first appears after which of the following lengths of time following a myocardial infarction? Is it 12 hours, 3 days, 7 days, 14 days? The answer is 3 days. The answer is 3 days, not 12 hours. See, I'll tell you, please note this. I'll give you a small explanation here. So, what is a clinical triad of a chest pain? When do you call someone is having an MI? Okay, you have to remember three things. That those are the cardinal signs, like that the chest pain, and then the ECG signs, and then you have the cardiac markers. So, what cardiac markers do you prefer? You prefer troponin, CKMB. Okay, what happens? These two markers, they gradually raise, and with 12 hours they reach to the peak, and then they remain standard for 3 to 4 days, and then CKMB starts to decline. But whereas troponin, it starts raising. That is why it is considered as a specific marker. Okay, we do ask for trop-T test, troponin test. Okay, and here neutrophilic exudation and coagulation necrosis, you see it in three. This is repeated question from yesterday's quiz. I mean the previous day's quiz. Okay, don't miss quiz. You miss a question. Fine. Next, leaderboard, please. Fine. Oh yeah, see, Sairam is coming up. Come on, everyone. A 72-year-old man presents with a sudden onset of a left flank pain. In the emergency room, he has hypotension, pulsatile mass in the abdomen, and the mechanism of this patient's disease most closely relates to a neoplastic process, elastic tissue fragmentation, atherosclerosis, and immunologic reaction. So, what, according to you, what are you suspecting in this patient having a left flank pain? So, what is situated here? No, it is not a neoplastic process. It is not elastic tissue fragmentation. Yes, it is related to atherosclerosis. And how do I say it is atherosclerosis? Given the clinical scenario for hypotension and a pulsatile mass within the abdomen, what do you suspect? It should be something, a rupture. The rupture of an abdominal aortic aneurysm. The most common site is below the renal artery zone, where there is less number of valsalvas. Okay, so now vasa vasorums, these are all less in number, so they are more prone to get injured and they develop aneurysms. Okay, the wall becomes loose and then they start as an outpouching thing. So now in this old patient, what is the clinical triad here? The clinical triad here is you have severe back pain, and you have hypotension, you have a pulsatile mass. So these are the three characteristics you should suspect here. Now, what is the gold standard test I'm going to do for this patient? It is simple. Ultrasound, abdomen will make me help to diagnose the patient that he's having a ruptured aortic aneurysm. Okay. And now, what type of aneurysms you have? If it is infectious, you have mycotic aneurysm. The most common organism is syphilis, Treponema pallidum. And then in a neoplastic process, I don't think you'll have a sudden hypotension and you don't have a pulsatile mass. What's a pulsatile mass? You feel it. It is vascular origin. Any mass which has a vascular origin, arterial line, it is pulsatile. Okay. So that is the answer here. Fine. Let's go to the next question. Leaderboard. Good. The Al is doing good. Sairam, Ravikumar, good boy. Fine. Good. So question number 7. Histologic sections from mass diagnosed as being osteosarcoma would reveal endothelial line spaces surrounded by multinucleated giant cells, haphazard arrangement of immature bony trabeculae forming, lobules of hyaline cartilage with few cells, malignant anaplastic cell secreting osteoid. See, what is osteosarcoma? Most common tumor, most common malignant tumor. So, what is your answer here? Fine, the answer is very simple. It's a malignant anaplastic cells. They secrete osteoid. What is osteoid? This is a bone which is not normally found, and these malignant cells will secrete the immature bone. This immature bone is osteoid. So presence of osteoid within these neoplastic cells, anaplastic cells, you call it malignant, and that is osteosarcoma. And endothelial line space surrounded by multinucleated giant cells, no, that you have different I mean histologically you have different names of benign situations. Haphazard arrangement of immature bony trabeculae, no, that is also not. Lobules of hyaline cartilage with few cells? No, that is also we don't find. Okay. Okay. Osteoid. Malignant osteoid is classic hallmark of osteosarcoma. Next question. Leaderboard, please. So, multiple myeloma and lymphoma, most common bone cancer in children. Okay. So, how many of you are good with pharmacology? Let me see. The action of streptokinase involves the formation of antithrombin 3, protein C, plasmin, and thrombin. I don't need to give an explanation for this because it's a straightforward question. And I won't give an explanation as well for this. Is it antithrombin 3? Is it protein C? Is it plasmin or is it thrombin? Streptokinase. So the answer is plasmin. Yes. No, it is not antithrombin. Antithrombin inhibits thrombin. Okay. And protein C also inhibits thrombin in the presence of heparin. Okay. So the answer is plasmin here. Okay. Next leaderboard, please. Oh, very good. There's a tough competition between AL and Indamur Sairam. Ravi Kumar and come on. Okay, ninth question. So 32-year-old woman who is pregnant with fourth child knows a mass on the anterior portion of abdominal wall. A biopsy reveals non-encapsulated infiltrating fibroblastic process with no evidence of atypical mitotic spindles. So what do you think is this category of disease? Is it malignant fibrous histiocytoma, fibromatosis coli, fibrosarcoma, or is it a leiomyoma? It is non-encapsulated. It does not have any atypical mitotic spindles. Uh, how could none of you wrote it as fibromatosis coli? See, the most common thing here, what is the patient presented with? See, she's having her fourth child. It means there is constant injury, or by cesarean section, there's constant injury to her abdomen. So, most common tumor which occurs in such kind of people is desmoid tumor. So what is desmoid tumor? Desmoid tumor is non-encapsulated and it is nothing but the exaggerated fibrous response for an injury. Okay. So it is not malignant here. It's not malignant fibrous issues because there are no mitotic or any anaplastic cells here. So it is simple fibromatosis coli. Okay. It is not fibrosarcoma or it is neither leiomyoma. Okay. Fine. Okay, next question. I don't think anyone answered this right. Let me see. See, the dashboard is same. Okay, next question. True regarding amyloidosis are all except massive proteinuria, mild hypertension, normal kidney size, urinary cast present. So do you have hypertension here in amyloidosis? Oh. See, there is massive proteinuria. There is, see, the kidney size is normal. Only in severe cases, it could be enlarged. In very few cases, but otherwise it is normal. Okay. Urinary cast, yes, they are present. Mild hypertension, you don't see hypertension in amyloidosis unless it is a very long standing case. Okay. Otherwise, you don't find hypertension. So please remember, this is a tough question for you all then. Amyloidosis, you have massive proteinuria, you have normal sized kidney, and you have urinary cast, but you don't have hypertension. You don't see hypertension in such patients. Okay, fine. The renin system is all normal. Okay, yeah. Next question, leaderboard, please. So you have glomerular involvement, nephrotic range proteinuria, impaired GFR, renal size is usually normal or very slightly enlarged. Yes, fine. Next question. Early changes of the structure of arterial walls leading to a condition known as atherosclerosis involve accumulation of lipids and progressive thickening. The cells thought to be involved in this early process are the endothelial cells, myointimal cells, lymphocytes, and macrophages. This I don't have to tell you all. Straight answer. The answer is myointimal cells. Very good. So, uh, what are these myointimal cells? Where do you find them? So, these are smooth muscle derived cells which are found within the intima. You know the three layers of the artery, like you have tunica externa, tunica media, and the tunica intima. From intima, these endothelial cells they just get separated, and from there the lipid starts accumulating. Okay, first there will be proliferation of these myointimal cells. Okay, that attracts the lipid accumulation, and then they progressively become thick. That is the pathology starts from there. Okay, fine. Leaderboard, please. Atherosclerosis is a beautiful question. If you read it, you'll just fall in love with that theory explanation. How does it origin? Fine. Okay. Next question. Chromosome number of cystic fibrosis is chromosome 5, chromosome 10, chromosome 7, chromosome 1, or chromosome X, sorry. CFTCR, cystic fibrosis transmembrane conductance regulator gene. It is in chromosome 7. Wow, very good. Very good. Majority wrote it correct. Chromosome number 7. So let me tell you all the chromosomes, a list of chromosome involvement here. So in Wilms tumor, it is 11p13 chromosome which is affected. It is 11 chromosome. Prader-Willi syndrome, it is chromosome 15. Neurofibromatosis 1, it is chromosome 17. Neurofibromatosis 2, it is 22. Alpha 1 antitrypsin deficiency, chromosome 14. Wilson's disease, it is 13. Adult polycystic kidney disease, 16 chromosome. Infantile polycystic kidney, which is autosomal recessive, it is in 6 chromosome. Huntington's disease, chromosome number 4. Alzheimer's disease, it is chromosome number 21, 14, and 19. Please remember. Okay. Leaderboard, please. Oh, yeah, you see, I see Sairam has taken the lead here. Okay. Next question. So, which of the following is true regarding viral hepatitis? Raised transaminase levels correlates well with hepatic injury. Variable elevation of transaminase in prodromal phase. HIV infection is diagnosed by IgG estimation. Elevation of enzyme is specific for liver injury. So, what is your answer here? Yes, very good. Majority wrote it correct. So, it is this variable elevation of transaminase in prodromal phase, you notice it, okay? And in HIV infection, it is not diagnosed by IgG estimation, it is diagnosed by IgM estimation. So, we are talking about the other options. Why are they not? Elevation of enzyme is specific for liver injury? No, it is not always specific for liver injury, okay? So, raised transaminase levels correlates well with hepatic injury. Leaderboard. Sairam, Ravikumar. Okay, Alkamane, you came down. Be active. And Aditya Narayan. There's a new name I'm seeing. Good boy. Come on, push up. Press fastly. Okay, next question. So this is a theory-based question. I'll read it out. Which of the following statement concerning lipids and heart disease is least accurate? Saturated fat should comprise no more than 30% of total calories consumed each day in order to lower the risk of heart disease. Coconut oil contains lauric, myristic, and palmitic saturated acids. Consider the worst saturated fat for increasing serum cholesterol. Trans fatty acids in hydrogenated vegetable oils with low density lipoprotein and decreased HDL levels. American Heart Association and the American Cancer Society both recommend at least 25 grams of fiber per day to help lower serum cholesterol levels and lower the risk of colon cancer. Yes, so we do have the three things correct, and one is least accurate, which says that saturated fat should comprise no more than 30% of the total calories consumed each day. No, it is no less than 10%. Okay, if you have 30% of saturated fats in a day, it is least likely the answer. So coconut oil, those are all the right answers, and you have the American Heart Association and American Cancer Society recommending at least 25 grams of fiber per day to lower serum cholesterol and lower the colon cancer risk. Okay, this is a long theory based question. Okay, leaderboard, please. Who is that one person who wrote it correct? Okay, Ravi Kumar wrote it correct. Fine. Next question. Yeah. If you listen for my explanation on the second question, I think you'll get it. Which one of the listed substances has the following characteristic serum changes following a myocardial infarction? Levels begin increase to 4 to 6 hours after the onset of chest pain and reach to a maximum concentration about 12 to 24 hours and remain elevated for about 3 to 10 days. Is it troponin, ALT, AST, CPK, isoenzyme, NB? Very good. It is troponin. Why do you keep CPK-MB? CPK-MB also will raise, but it will gradually decrease after reaching to a maximum point at 24 hours. It starts to lower down. Okay, CPK-MB. Fine. So, what are the characteristics of MI? ST elevation. Okay, and then you have inverted T waves. So you should read the ECG changes in MI. Okay, the triad, the clinical triad of clinical chest pain, ECG changes, and the altered cardiac markers. Okay. Next, leaderboard, please. And why TROP-T is preferred to CPK-MB is it stays longer. Okay, it increases in Ravi Kumar, very good. Sai Ram, Neelu Sharma. Okay, fine. Yeah, next question. Parathyroid hormone, by its actions on target organs, is known to cause all the following except increased intestinal calcium absorption, increased renal tubular reassertion, increased serum phosphate levels, mobilization of calcium from one, decreased renal tubular reabsorption of phosphate. So the answer here is yes. So you have increased intestinal calcium absorption, you have increased renal tubular reabsorption, and then you have decreased serum phosphate levels. Okay, and then you have this decreased renal tubular reabsorption. See, when there is decreased reabsorption, there will be increased loss. So what will happen to the serum levels of phosphate? Serum phosphate will be decreased. And also remember, calcium and phosphate are two, just like sodium and potassium, and they calcium and phosphate, when calcium influx happens, potassium outflux. So these two are opposite, they operate in an opposite way. More amount of calcium, and you know what is parathyroid hormone doing? It is taking a lot of calcium in. Okay, so there is be less amount of calcium within the stream, more amount of calcium within the stream and less amount of phosphorus. Okay, when calcium is in, phosphorus is going out, exchanged ions. Okay, fine. Next question. Ravi Kumar. Oh, good. Sairam. Push. Hello, Aditya Narayan. Good boy. But anyway, I'm very happy to see the first five names. Huh? For me, all five are winners. Next question. A specimen from a lung biopsy reveals occasional plexiform lesions with pulmonary arterioles. This abnormality is most characteristic of Churg-Strauss syndrome, adult respiratory distress syndrome, venous granulomatosis, pulmonary hypertension. So what is your answer? You have arterioles. You don't find normally pulmonary arterioles within the lesion unless there is elevation of the pulmonary arterial pressure, which is which makes pulmonary hypertension the answer. It is not Churg-Strauss syndrome. You have eosinophilia here. Adult eosinophils are more in Churg-Strauss syndrome. Adult respiratory distress syndrome (ARDS), no, you don't have the plexiform lesions. Okay, within the it is pulmonary arteriole. Venous granulomatosis also not. In pulmonary hypertension, you do have this occasional plexiform lesions within the pulmonary arterioles due to increased blood pressure, increased pulmonary arterial pressure. Okay, so that is the main cause of the lesion here. Okay, Let's see the answers. 4 of you wrote correct. How many on the leaderboard? Last 2 questions. Last 3 more questions. Good. A specimen from a lung biopsy reveals yes. Okay. Oh, fine. This is a tough competition. Sairam, very good. Ravi Kumar, also. There's a little gap, I think. Which of the following cells found within the liver is a major source of the excess collagen deposited in cirrhosis? Hepatocytes, Kupffer cells, Ito cells, and endothelial cells. So, in cirrhosis, zone 3 is affected, and zone 3 cells are Ito cells. Very good. Majority of you wrote. So, these are lipocytes. Ito cells are lipocytes, and these are found in the zone 3. And zone 3 is most commonly affected in cirrhosis. Okay, fine. Leaderboard, please. Good. You don't need any explanation. When majority wrote correct, I'll skip this explanation. Sairam, very good. Suhi, push up. Which of these is true regarding CML, chronic myeloid leukemia? Size of splenomegaly indicates prognosis. Phagocytic activity of WBC is reduced. Sudan black stain is specific for myeloblast. Myeloblast, granuloblast, and lymphoblast are Philadelphia chromosome positive. So, what is your answer here? Which is true here? Size of the spleen indicates prognosis. That's right. That's the right answer here. Myeloblast, granuloblast, and lymphoblast are Philadelphia chromosome positive. It's not just them. Everything is, all cells are Philadelphia chromosome positive here. Even erythroblast as well. Okay. So the Sudan black stain is specific for AML. Okay. You can see that in a myeloid blast. And phagocyte, see, this is regarding CML we are talking. Okay. Here in CML blast is what he meant here. Sudan black is not positive here. Phagocytic activity of WBC is reduced. No, in AML it is reduced. Please remember. The size of spleen indicates prognosis. Yes. So there are few prognostic factors like this: increases percentage of circulating blast, the spleen size, the platelet count, the age, and the cytogenetic clonal evaluation. So if the patient with Philadelphia chromosome, have good prognosis. Okay. Fine. Next question. Leaderboard, please. Last question of the day. Hmm. I could see Sairam neatly occupied the chair, and Ravi is struggling. Alchemy performed very good. Yes, next question, last question of the day. Which statement is false regarding familial adenomatous polyposis? Men are usually carriers. Autosomal dominant inheritance, if not treated, progress to malignancy in 100% of cases. Males and females are equally affected. Oh, yes, that's nice. So, familial adenomatous polyposis. So, this is a very beautiful syndrome of, you can give a two-hit hypothesis. You know this story, no? In pathology, you have this wonderful concept of two-hit hypothesis. So, that fits very well for familial adenomatous polyposis, where, see, it is autosomal dominant inheritance, that we know. And when there is autosomal dominant inheritance, why are men preferred here? So men are not preferred. Men or women are equally affected. So that rules out the first option, that males are usually carriers. That doesn't exist. Autosomal dominant inheritance, yes. If not treated, they progress to malignancy in 100% of cases. Yes, that is true. Okay. So that concludes our class for today, our quiz session for today. Let us see who is on the leaderboard. Ah, there. Sairam is there. Good job, Sairam. Keep it up. And I wish most of you to participate. I see Sairam so curious, asking when is the quiz, and all, right? Sweet. The Jeel should be there. Congratulations again today. Hearty congratulations. Study well. To everyone, no? To everyone, even to Ravi Kumar and Alkamini, you did very good. Hello, S. Good boy. Fine. Aditya Narayan. So yeah, I wish to see some girls' names, please, here from tomorrow. Fantastic then. Have a nice day. Good night. Bye bye.